to Brian Sillanpaa's Patho class.
I don't know what class they're in.
We're going to talk about muscle weakness and difficulty walking.
You act so different when you're in front of a camera.
I didn't say anything yet. All right, so anyway, talk about MS, ALS, and probably not get much further than that today. Either way, you'll probably want to break that up, by the way, after each thing. So after MS, stop, hit again.
Okay.
Okay. Yeah, I really don't have a lot to say about this. This is pathophysiology. You guys kind of got the whole nervous system thing, I hope. We are going to be talking about, however, this myelin sheath. Okay? Myelin sheath, made by oligodendrocytes. It protects the axon. It helps speed up nerve conduction. Makes it so that it has that, remember, that saltatory nerve conduction where you don't lose any speed because it keeps rebooting it at those nodes of Ranvier or whatever it's called, right? Okay. Start out with this. Your friend Kelly came to you with some questions about her mother. Lately, her mother has been having episodes of generalized muscle pain and shaking. She went to her doctor who said that she thinks that Kelly's mother might have multiple sclerosis and wants to do some tests to confirm her diagnosis. What test will be a definitive diagnosis for MS? And of course you know this because you read ahead, right? So.
You can't do iPhone of death.
So. I know I can't do the iPhone of death. You're holding my iPhone. So let's just pick Jessica.
What?
You were giving me a hard time.
What?
Hi. I was going to read the PowerPoint and tell you.
Well, you got, 1 out of 5 chances. What do you think?
Okay.
No. What else?
What? It's not an answer. Okay, it's not an answer. I want to say A, but
Okay.
that's a guess.
Yes, that is a guess.
Yes, it is. And I,
That is incorrect.
I tried.
You tried.
Failed.
Good job. Anybody else want to take a try? Oh, I'm so glad you guys are reading ahead.
Would it be,
No. I don't know. Spit it out, one.
okay, D?
It is actually D. Oligoclonal bands on electrophoresis. Okay, so that we will see.
That's right.
All right. So, MS. Some things about MS. First off, sclerosis means hardening. That's what the word means. Okay? So, in multiple sclerosis, the end result is you're going to have sclerotic plaques on these axons, as in the myelin itself kind of gets degenerated, yeah, and it gets hard. Okay, so you can't conduct nerve impulses like you should. So this is again one of those degenerative nerve diseases where in the end you're going to be messed up cognitively, physically. So let's kind of look at it. Oh, as far as this part goes, the 4 different types, we'll see its own little PowerPoint slide on that. But depending on, I don't know what it actually depends on, but different people will present over a course of time different ways. Most people, they'll have a bad day, and then they'll be okay. And then have another bad day, and then be okay. And so forth. So they have good and bad days. That's the remitting, relapsing part that happens to most people with MS. We have some other options, and again, I'll show you those when we talk about them in a second here. Alrighty. Was there somebody in this class that did a paper on this, on MS? That wants to admit it? Okay. Because there are some things on this PowerPoint that we're trying to exactly nail down. So, for example, it says autoimmune. Okay. You remember our rule for when it's autoimmune, you can find some specific protein or something in the blood, some kind of factor that says this is it. I don't think that they found that yet. Okay? They know it runs in families. So, autoimmune things run in families. Well, so do genetic things. But they haven't, as far as I know, found any genetic connection to say it is on this gene at this locus and that sort of thing. All right? So, of course, what do we do when we don't know? And we think it might be autoimmune or genetic related or a genetic predisposition for it. that some kind of environmental factor kicks it in, right? We kind of say it might be, we say it runs in the families. That's all we can really say, right? And sometimes we blame it on virus infections because, you know, who knows?
Wait, we say it runs in the family if it just is like.
We know it runs in families,
Okay.
but not everybody in the family gets it.
Okay.
Okay, and they haven't found any specific gene, as far as I know. Things change every day, but as far as I know, they haven't found any specific gene that says this is it. So, what they do know is some weird statistical things. For example, like environment. The further people live away from the equator, the more often they get multiple sclerosis.
That's weird.
It is weird. Okay, which kind of got them thinking, well, okay, what's different near the equator versus far away from the equator? The heat, the sun, right? So they start looking at sunlight and vitamin D, because you know you can make that calcitriol, right? By activating vitamin D from sunlight on your skin. So they start looking at that, and they actually did find that vitamin D helps alleviate some of the symptoms and slow it down, apparently, when people do get MS. I don't know that they found a direct link other than that, but at least they have that so far. Okay. Again, depending on, of course, what nerves are affected, this is a central nervous system problem. All right. Now, when they say it's autoimmune, what they mean in this case is that they're pretty darn sure that what's happening is the immune system, the T cells, the B cells, I don't remember which other ones happen to be involved in this specific instance, but they're getting into the blood-brain, or getting through the blood-brain barrier, and they're attacking the myelin. Okay, so we know this is our own immune system attacking the myelin inside the central nervous system. Okay, so that by definition would be autoimmune. The thing that causes that, that's kind of what I was talking about. That's the part where we're kind of unsure of. I don't think anybody's figured that part out yet. Okay?
So they think it's autoimmune, but they don't have enough on the antigen.
Exactly.
Okay.
So they haven't found the reason why our immune system is attacking, but they do know that our immune system, T cells especially, and then B cells, and one other one, I don't remember which one, but they are definitely attacking inside the CNS, definitely attacking the myelin sheath. So by definition, that is autoimmune, but usually you want something, you know, some kind of factor or protein to say this is what caused the whole problem.
Yeah, that's why it's weird.
It's kind of not there yet. Okay?
You said it goes past the blood-brain barrier?
Mm-hmm.
Okay, so it's in the brain, not in.
It's in the central nervous system.
Which isn't that
The central nervous system is what's being attacked. I'm not sure. Was I cutting you off, or there's something else?
No,
Okay. Anyway, again, it really depends on what's being affected, but with multiple sclerosis, patients can have anything as far as what you might expect if your central nervous system is being attacked. Okay? So there's always going to be nerve problems. There's always going to be a pain associated with the nerve problems. Okay? Now, it might primarily hit visual, for example. So you can see some visual problems, optic neuritis, if it happens to be hitting those particular nerves. Okay? You'll see sometimes somebody will like lose their arm, for example. They lose their right arm because that happens to be the part that's getting hit first with this demyelination. Yeah, it's like the movement. You can't, no strength, no movement. It totally hit the central nervous system that happened to be innervating the right arm, for example.
Did you talk about the T cells?
I mentioned it. Do you have more to add on the T cells?
Well, it says that somehow they become sensitized to proteins in the CNS, and then when they become activated, that's when they start causing the inflammation and damage, and causing the chemicals in the nerve fibers in the axon. But they don't know why and what causes the T cells to actually do that, so they can't quite name it, like you said, autoimmune versus genetic versus
Yeah, but I mean, by definition, if the T cells are attacking
Right,
itself,
right,
that is obviously your own immune system attacking you, right?
right.
But that's what they're searching for, I think, at this point, is why? Why in the heck would your own T cells attack your central nervous system?
How do they figure out that the T cells are attacking the central nervous system if they didn't find the antigen?
They don't know exactly how it's getting in there in the first place and becoming active in it and actively attacking.
How do they know they're doing that?
Because they can biopsy that part and they can look at it and see them.
Take a sample of the spinal fluid.
Okay.
That too. Okay? So anyway, all of these things, this is a lot of stuff. Again, central nervous system stuff, everything is pretty much covered here, right? Balance, memory, weakness, muscle paralysis, tremor, unsteady gait, kind of like the Parkinson's thing. A little bit of Alzheimer's-like stuff, a little bit of Parkinson's-like stuff. You just slowly getting worse. It is, like I said, a neurodegenerative progressive disease. Okay? It does get worse over time, but how it gets worse over time is kind of individualized. All right? Do I want to add anything else on here? Not really. Yes, sir.
Will this eventually kill you?
Eventually, yes.
You stop breathing.
It is over a very long period of time. This is kind of slowly progressive. But yeah, it's a central nervous system issue. Eventually, it's going to shut things down one at a time. And people with MS usually end up in a wheelchair many years before they actually die. It is. It's actually very sad. Okay. Now, where was I going to go with that? Healthy brain, what you don't see is these little white plaques. Okay, you see these little white plaques all the way through there. We know that these sclerotic plaques are indicative of multiple sclerosis. You can see them.
Are those on the myelin? The plaque?
Yes, the myelin itself. You know how we were talking about like glomerulonephritis, where you had that antigen-antibody complexes, and they like lay down these plaques, you know, and it can cause infective endocarditis and glomerulonephritis. Same kind of thing happening here with your immune complex. So your T cells are attacking the myelin itself and causing
Like plaques to stick
plaque.
to it?
Yeah.
So the myelin's still there,
It's
it's just
eating
like-
through the myelin.
Oh, it's eating.
It's eating through the myelin and causing it to be hardened and scarred. That's what sclerosis means, is a hardening, scarring of it. Okay? But you can see that on imaging because of the hardened, scarred part. Okay? So here's what I was talking about in case studies, oligoclonal bands. What they say is 90% of people with multiple sclerosis will show on electrophoresis these oligoclonal bands. Okay? Has anybody in here had enough lab in this that knows what the heck this is? Dylan, you want to explain these?
What do you, wait, what?
Wait, what? Electrophoresis, IgG, oligoclonal bands. Any idea of what? Tell me about electrophoresis.
Well,
That's
you
what I meant.
take a sample of whatever you want to identify, and then an electric current runs through a gel, which that's a picture of a gel, and everything in the sample separates out depending on how heavy it is. And so I don't know specifically what the IgG oligoclonal bands does, but I mean, it's something on it, so it's going to make it heavier, so it's not going to move as far. So that's why it's near the top of the gel, rather than down at the bottom with everything else.
Good. That's exactly what I wanted. Big proteins move slower than little proteins, right? When you throw the charge on them, that's the whole the premise of the electrophoresis. And you see this again in 90% of people with MS. You will see these IgG, that antibody, right? Oligoclonal bands. That doesn't mean it's necessarily that you have MS, but if you take it and combine it with the other physical signs and symptoms that we were talking about, that's pretty darn diagnostic, right?
I feel like it's not very obvious.
What is
Like
not
the
very
bands,
obvious?
they're not very obvious.
Oh, it's obvious. That pattern, that specific pattern is
Really?
pretty darn obvious if you do this for a living.
Okay.
And they know exactly what they're, it's kind of like jumps out at them, like, whoa, there it is. Okay.
So you'd start like, you test for that, like if someone started showing symptoms, right?
Yes.
Okay. And then there's no like treatment, so you just like, you know.
There are treatments. There's no cure. There's a difference. By the way, did I mention it's fairly young adults at this age? You know, in between your age and mine is, I'm safe, I'm good, you guys aren't. Okay. All right, so here's what I was talking about. The whole MS thing. Remitting, relapsing, 90% of the time, this is what your patient is going to have. They're going to experience, as in, they're going to have a really bad day. And then it'll be okay for a while. And then they'll have maybe another bad day. And then it'll be okay for now. And then another bad day. And it comes and goes. It remits, relapses. But notice that eventually that baseline gets higher and higher because it is progressive. Okay? As opposed to this primary progressive where it just gets worse and worse and worse. They don't tend to make it as long. And then we have a little bit of both. And, you know. So anyway, those are your 4 kinds of
So
how
you
it tends to
either have-
present in people.
You have one. You can never like, one wouldn't go from a remitting.
Don't ever
relapsing.
say never because yeah, they do sometimes.
Okay. But most common.
In fact, this
you
would be a
get
good
one type.
example of it right there. You would just call it secondary progressive,
Oh, right.
right? Because you started out with remitting relapse, but then it turned into that
Right.
progressive. Okay. Here's another one. It's the same thing. If you prefer this instead of the other. Visualization.
So what are the treatments then? They were all.
You're right. Treatments are not on here. Again, a lot of it is unfortunately palliative care. Okay, and oh my gosh, I wish I could remember all the treatments. Initially, you pretty much start out with some kind of corticosteroid to bring down the inflammation, bring down the inflammatory process. That helps to some extent. There are some very specific drugs, and I can't remember the name of them right offhand. I know there's like 3 main drugs that people use to try to slow this down.
Is it the same as the ALS, like cortisol? Would that be used for MS too?
I don't know if that's one of them or not. I honestly can't remember right now. Anyway, we can look it up later, I guess. Have you ever noticed, by the way, that a lot of times we don't really deal with a lot of treatments in this class? You ever notice that?
Mm-hmm.
That's on purpose because treatments change so fast, and we want to teach just the basics in this class, and then when you get to nursing school and med school and pharmacy and whatever you're going into, PA, then you can learn what current treatments are, because you know we can't keep up with teaching the basics and going through other treatments, right? Oh yeah, I can't check my phone. What time is it?
You have 1 minute.
I got like 1 minute.
What?
Okay, I know. We were having so much fun. We'll call it good, and this is going to lead us actually into ALS anyway, this next slide, so we'll see you Friday.